For decades, millions of women reporting systemic hormonal disruptions were evaluated through a single, highly specific lens. Doctors would routinely move an ultrasound wand across the patient's abdomen, searching for physical cysts on the ovaries. If no cysts were visible, the diagnosis was frequently dismissed. An official publication in The Lancet has identified this diagnostic approach as incomplete. The medical community is reclassifying Polycystic Ovary Syndrome, PCOS, to PMOS, Poly-Endocrine Metabolic Ovarian Syndrome. The previous name centered the medical focus on a localized structural symptom, the cysts. This instructed practitioners to prioritize imaging of the reproductive organs over the patient's internal chemistry. This created a clinical paradox. Patients would show every symptom of severe hormonal distress, from hair loss to rapid weight gain, yet their ultrasound scans would appear completely normal. These symptomatic patients were often denied treatment because they didn't meet the physical criteria of the old name. They were left to manage a systemic disorder without a diagnosis. The medical community now identifies this condition as a systemic failure of cellular energy regulation. The presence or absence of cysts is no longer the defining factor for the disease. Shifting the nomenclature to PMOS forces a change in treatment. Clinicians are now required to address the metabolic root cause rather than waiting for structural changes to appear on a scan. Poly-Endocrine signifies multiple interconnected hormone networks malfunctioning simultaneously. Metabolic identifies the cellular origin. The syndrome begins when cells develop insulin resistance, disrupting energy distribution. The ovarian element is a downstream effect, where fertility issues are consequences of this failure. Finally, syndrome classifies the consistent, interconnected pattern. This framework allows clinicians to restore the function of the entire endocrine network. The cascade begins when cell membrane receptors start repelling insulin. Unable to absorb energy effectively, the body enters a state of deep metabolic stress. To compensate, the pancreas secretes high volumes of insulin into the bloodstream, attempting to force the resistant cells to accept the fuel. Testosterone disrupts the natural menstrual rhythm. The chemical surge prevents follicles from maturing, halting the ovulation cycle. This specific chemical collision is the reason for irregular or absent periods. The hormones are physically preventing the reproductive system from completing its normal process. This entire process occurs at a biochemical level. It does not require the formation of physical cysts to disrupt the patient's fertility or health. A clear ultrasound scan does not change the reality of the androgen surge. The syndrome is defined by these circulating chemicals, not by the appearance of the ovarian tissue. Because PMOS is a systemic failure, accurate diagnosis requires mapping the patient's blood chemistry rather than just imaging a single organ. Modern protocols use a high-fidelity biomarker map. First, fasting insulin and HOMA-IR scores populate to measure cellular resistance. Next, tracking androgens like testosterone and DHEAS reveals the hormonal surge. Finally, adding SHBG, FSH to LH, prolactin, and TSH completes the interconnected web, providing a full view of the hormonal landscape. While an ultrasound shows only a moment in time, this panel provides a real-time map of the physiological processes driving the syndrome. Identifying these metabolic markers is vital because the risks of PMOS extend into every major system in the body. Chronic cellular resistance often leads to the development of type 2 diabetes and the elevation of triglycerides, which are fats found in the blood. High insulin promotes visceral fat, an active tissue wrapping around organs that releases pro-inflammatory chemicals. These markers build arterial plaque, increasing the risk of ischemic heart disease. Furthermore, these cytokines cross the blood-brain barrier, interfering with dopamine and serotonin, directly linking the syndrome to severe anxiety and depression. This deep metabolic root links reproductive health directly to the long-term stability of the cardiovascular and nervous systems. Treating PMOS requires addressing the metabolic environment. Suppressing symptoms without fixing the energy regulation failure will not prevent long-term health decline. The management framework starts with dietary intervention. Selecting foods that avoid rapid blood sugar spikes manages insulin effectively. Strategic exercise follows, forcing cells to improve insulin sensitivity and absorb glucose. Finally, stress management regulates cortisol, breaking the hormonal inflammatory loop, keeping the syndrome active. If you are experiencing systemic symptoms, ask your doctor for the specific biomarker panel used to diagnose PMOS. Subscribe to the channel for more evidence-based breakdowns of medical research and diagnostic advancements. The shift to PMOS represents a more accurate understanding of women's health. You cannot address a systemic metabolic crisis by looking only at a localized structural map.